Hello everyone, this is Jenny and I just wanted to give you a little update on how my OBGYN rotation is going and give you a little tip or give you some tips that might help you out on your rotation. So today I just finished my COMAT exam. I think it went well. You don't care how I did, right? So since my 2-week update, I've seen one other vaginal delivery and one C-section. And I know that doesn't sound like a lot because it isn't. But I did get to do that one vaginal delivery. Yay! Small victory for me because 1 is better than 0. The title of this is How to Avoid Pimping by Your OBGYN. And for those of you who don't know what pimping is, it's when your preceptor continuously asks you questions until you get a question wrong, and that enables him or her to gauge your knowledge level and from there teach you. And so I wanted to make a list of the 5 mainly asked questions, at least in my rotation, so you would know the answers so you could give off that good first impression. Okay, so I wrote them down and let's get started. Question number 1. What labs are ordered during prenatal care and during what time frame? And I will bet you my left ovary that every OBGYN, no matter who it is, will ask you this question because it is so relevant within their clinical practice. So during your first prenatal visit, you're going to want to do a CBC, RH factor, and type-in screen to see if your mom is blood type, to see if she's RH negative. Then you're going to want to give Rogram later in the pregnancy, and then you're going to want to check for infectious disease because this can affect the pregnancy as well. So you're going to want to do a pap smear, gonorrhea, chlamydia, hepatitis B, rubella, syphilis, and if they're at high risk, you can do HIV screening, you can also do TB. So those are during the initial visit for everyone. And then around 9 to 14 weeks, you can do a triple screen, and then second trimester you do a quad screen. And then during 24 weeks, you would do check for a glucose test for gestational diabetes, which is a 50-gram 1-hour glucose challenge. And if they're positive, which means that their blood glucose is over 140, then you're going to want to do a 3-hour glucose challenge test. I think that's, well, the 3-hour one where you give them 100 grams and they go in fasting. If their blood glucose is high, then you're going to want to change their diet, and you want to tell them to exercise, change their diet, and then if that doesn't work, you can give them insulin. And then at 28 weeks, if they're RH negative, and you're going to want to give Rogam. And then during the 35 to 37 week mark, you're going to check for GBS. So know all those, because there will definitely, probably, ovary guaranteed, going to be a question on that. Question number 2. What consists of a reactive tracing on NST? So NST stands for non-stress test, and we do this for patients who are at risk or at high gestational age, GDM, eclampsia, stuff like that. So the 4 things you look for on NST is 1, baseline, 2, variability, 3, accelerations within at least 2 accelerations on that 20-minute time frame, and maternal contractions. So when you're reading off an NST to your preceptor, you want to list all those things, and preferably in order. So you'll look at your paper or the NST strip and you'll say, for example, fetal heart rate is detected at 130 beats per minute baseline with moderate variability. Accelerations detected, no maternal contractions, which is consistent with a reactive NST tracing. He or she will think you were so smart. Question number 3. In my location, there are a lot of patients that were diagnosed with PCOS. So the physician would always ask me, what is the diagnosis for PCOS? And you have to remember that it's 2 out of the 3. So if they have any 2 out of the 3, then they're considered to have a diagnosis of PCOS. Number 1 is oligo or amenorrhea. Number 2 is hyperandrogenism, and number 3 is if they have like the ring of pearl signs on ultrasounds, or cystic kidneys, cystic ovaries on ultrasound. And so 2 out of the 3. Most of the time they don't do the ultrasound. So, and what's the treatment? So if the patient wants to get pregnant, usually it's clomiphene and plus or minus metformin. And if they don't want to get pregnant, then usually it's oral contraceptive pills. Question number 4. What are the cardinal movements of vaginal delivery? So first is engagement, descent, flexion, internal rotation, extension, external rotation, and expulsion. I'll link a YouTube video below that my preceptor actually played for me after the vaginal delivery, just so they walk through everything. Oh my god, there's a huge moth! Ah! Oh my god. Oh shit! When the baby comes out, you label it by the occiput. So say the occiput is it's up towards the mom's pubis and not her rectum, and to the left, it's LOA, left occiput anterior. If it's on the right, then you say ROA, right occiput anterior, you know, stuff like that. So that's how you label it when the baby comes out. Question number 5, last question. What are the layers that you go through during a C-section? So my preceptor always likes to ask, like, what's that incision called during a C-section? And it's called a phalangeal incision. So after the phalangeal incision, you're going to go through the skin, through the subcutaneous, through the fascia, through the muscle, through the perineum, dissect back the bladder flap, and then you get to the uterus. And that's it. And that's all the questions I have. Hope this helps you out on your rotation. And if you like this video, please subscribe for more videos. I will hopefully be more consistent with this. Alright, see you guys later. Bye!